Any speakers that have presentations to make now? The technical room needs your presentations.
Get ready to supercharge your live streaming experience
So
with
no-
Stream Studio.
no
Absolutely
presentations are
everything
going to
you
be
need
used.
to run a successful live broadcast
presenting?
right from your.
Have you sent it? They have it? Okay. So Miguel already has it and Carlos,
Calderon.
Carlos Calderon. I'm not sure.
If Carlos was coming.
No, he said virtual, yeah.
Is virtual? Okay.
Yeah. I think I'll follow the
Okay. Yes, and we are live now. As I'm sure, I hope that speakers who are remotely, can you please identify yourselves by putting a guest speaker on your name tag, so we identify you on Zoom also, and we can kickstart the session any minutes now, as we have to fulfill a busy schedule today. So Ricardo Cruz Correia, it's professor at the Faculty of Medicine of the Universidade of Porto. Is also president in several civic platforms, associations, namely e-Mais, and a well-known teacher in this house, so it does not require further presentation for the ones attending here in presence. Ricardo, the floor is all yours.
Okay. Thank you, Paul, for the introduction. So in this session, we are going to try to answer this hard question: how do interoperability standards impact health data quality? And in particular, what incentives would definitely scale up the interoperable sharing of health data? So somehow two very hot topics: interoperability on one hand and data quality on the other. So we are going to try to explore somehow how these two are connected, if they are helping each other, or on the other way around, they are somehow creating issues to one another. So the first presenter will be Carlos Calderon, and I think he's online, so he's not here.
Is online already? Yes.
Yeah.
We see
Yes,
him.
can you hear me?
Perfectly.
Yes, we can hear you, Carlos, loud and clear. Welcome to the hybrid meeting.
Okay, thank you. Hi, Ricardo.
Hello, Carlos. Well, I think you can start your presentation if you agree. Carlos is actually a representative of the Spanish Association of Health Informatics, but I think if Carlos is willing to, you can also present a little bit of yourself and your current roles. Okay.
Can you see my screen?
Yep.
Yes.
Yep.
Okay. Okay, thank you for Health Data Forum for the opportunity to present this Spanish experience related of how can use standards of medical clinical information. In this case, my name is Carlos Luis Parra-Calderon. I work in public healthcare provider in Andalucia, in the south of Spain, working in the University Hospital Virgen del Rocío, and also I am the head of one research group about computational health informatics in the Institute of Biomedicine of Seville. In this case, I represent the Spanish Society of Health Informatics. I'm a member of the board of SAIS, this is our society. And I am also is the representative of Spain in the European Federation for Medical Informatics. And also I am the member of the board. I am the treasurer of EFMI. And this is my context to present this work today. My presentation, the title is how do interoperability standards impact health data quality for precision medicine research? Because today I present one Spanish strategy to develop the research in precision medicine funded and supported by National Institute of Health, Carlos III in Spain. The name of this program is Impact Data. Okay. The purpose of the presentation is explore the challenge of finding the formula that combines interoperability standards to enable a secondary use of healthcare data that makes data sharing feasible with medicine research at the national level in Spain. Okay, what is impact? Impact study is a mission of the Spanish government to establish the pillars to facilitate the effective deployment of precision medicine in the Spanish national health system, ensuring scientific technical quality, equity, and efficiency using available scientific resources to answer the needs of citizens. This strategy developed three foundational pillars. Three pillars named impact predictive medicine, impact data science, and impact genomic medicine. Developed three strategies and connected with two transversal strategy lines, one related of ethical scientist integrity, and the second is related of internalization of the study. The program related to predictive medicine will set up a population-based multi-purpose cohort that will allow the integration of data on life habits, clinical information, genetic information to generate predictive models. We name it with difference, of course. It's all of us in Spain. All of us is the American strategy, US strategy related of cohort of the US population. This is in the context of, in Spain, this part of the strategy of impact. The genomic medicine program is the third pillar, but I will speak about our pillar related to data science and the last. The genomic medicine program will act in two main objectives. Will provide genomic support to the cohort, to the predictive medicine program, and also to provide services using technologies currently in the research framework through high-performance sequencing center to help diagnose people with undiagnosed disease. In this case, this second objective is support the healthcare. The impact strategy is related to research, but in this case, connect one objective of research with the needs of healthcare in this context. This diagnostic orientation includes rare disease, hereditary tumor, or rare tumor variants with no identifiable histological lineage. An impact data science program is I work in this. Will develop and incorporate the necessary technological tools to connect the clinical information in the broadest sense and the data generated in impact, to lay the instrumental foundation to anticipate the next leap in health protection, always from a research perspective. Sorry, the next paragraph is Spanish, but in the objective general is to develop the first iteration of the needed infrastructures and protocol to coordinate, integrate, and manage clinical data. In medical imaging and genomic, with the final objective to support, to develop tools, validate tools to support the implementation for precision and personalized medicine in healthcare system, and in the context of legal framework and organizational framework in Spain. Okay. But what is the relation between impact data and the Spanish Society for Health Informatics? The National Institute of Health, Carlos III, in the call for the data science program required it. The proposal must include an implementation and coordination plan with the national health system IT experts, including the participation of all the autonomous community and cities. In Spain, the public health care is delivered by regions. The regions are named in Spain autonomous communities because it's the names for the the governments at regional levels in Spain. This is healthcare providers, healthcare public providers are supported by autonomous community, supported by regions in Spain. The Spanish Society of Health Informatics, through an agreement with the Spanish Minister of Health, hosts the coordination of IT managers of public healthcare providers in Spain. In the field of interoperability of health information between regions, through this name, the Technical Committee on Interoperability. This technical committee is an official committee supported by the Spanish government to coordinate actions related to interoperability, and in the context of the agreement with the Spanish Society of Health Informatics. Impact Data also has an agreement with the Spanish Society of Health Informatics, and Impact Data participates by providing information advisor to this committee and receive feedback so that the Impact Data infrastructure must be viable and scalable in the national health system. This is the connection between Impact Data program and the Spanish Society for Health Informatics. And how Impact Data address the clinical information standard. Related of one of technical objectives in Impact Data is Impact Data must develop and implement of protocol methods and integrated data analysis system based on databases, structured methods, evaluation system, and verification mechanisms. Verification mechanism is related of apply FAIR principles. FAIR principle is about make data findable, accessible, interoperable, reusable in the context of research. And other technical objectives related to how develop an initial development of systems for the semi-automatic and secure extraction of minimum standardized and pseudo-anonymized information from health information system, of course, the electronic health records, with development of interoperability and standardization protocol based on national and international standards. Impact Data developed this task in the Work Package 4, implementation of systems for the analysis and interpretation of medical data. Oh, sorry. Okay. And the next final two slides is the more relevant about my presentation, I think, today. We developed some tasks in the context of this work package. This work package is currently ongoing, also this year and next year. But we developed two deliverables in the context of the work package, and we can present some conclusions and recommendations related of how can use a standard for the secondary use for clinical data for precision medicine research, and also what about the quality of data. Related to the recommendations in the work of Impact Data program is very clear. We detect various health data models and standards support secondary use, but not in a perfect or probably complete way. Any can support all the needs of secondary use for precision medicine research. And some solutions overlap in whole or in part with others in the solution space. Others, some niche standards respond to particular issues or problems, while others have a much more universal vocation, which perhaps make this less precise and addressing some specific issues. It's relevant, the type of use cases, because maybe in the future, when we continue to implement the need to work with data of different use cases, we will need change the combination of standards to address the best solution for precision medicine research in every use case. For example, it's not the same as addressing federal lending projects in which algorithms are executed in a distributed manner in nodes that will necessarily have to have homogeneous data model, as it is to address centralized aggregation projects in which the data model for analysis has a single location, but in which it's necessary to establish mechanisms for data transfer and above all to achieve a perfect conceptual mapping of the central model with different models existing each of the data providers. Okay, sorry. What about the quality of the clinical data? At the end, it's not very new conclusions. The quality of data in the system is critical to result correctness. It's clear. But we detect the relevance of connect and the feedback between the data source, the pipeline of secondary use for precision medicine research, because during the data analysis process in secondary use, we detect some needs to improve the quality of data or in the origin, in the data collection in electronic health record. We need to implement a specific process to feedback the problems at the end of the pipeline in the part of data analysis, and the application standard at source, of course, in electronic health records, of course, but also in secondary use. For example, it's not the same. We can use archetypes or ISO 13646 at the electronic health record level, and also we can use OMOP for secondary use. And we must, if we detect some problems related of dimensions of quality of data in the process of analysis in secondary use, we must develop methods to connect with the original archetypes to detect in the origin the problem. I think this is one I think important conclusion of this first deliverable first work in the context of work package 4 in impact data related of how can apply clinical standards to precision medicine research. And that's all for my part, and thank you for your attention.
Thank you, Carlos, for the presentation. I think we'll get the questions in the end. Maybe it's easier to maintain the timetable. And now we are moving to Catherine Chronaki.
Do I need to move there?
Well,
if you prefer, you can move there.
Catherine is currently the Secretary General of HL7 Europe, and it was until very recently also the President of the European Federation of Medical Informatics. So welcome, Catherine.
Just the logistics. I changed the slides here, right? Okay.
Yeah, you should.
So thank you very, very much for the kind invitation. It's so nice to be in a person event here in Porto. It's a beautiful city and such a warm atmosphere, and I appreciate that. And I'm very grateful that I will be able to share some of my thoughts about data quality and the role of standards. So what is our role to play? And listening to Carlos earlier, I actually made a note. And the note I make is how important is quality at the source, something that was reiterated in the beginning in the great opening session, but also the feedback loop, going back, giving value back. But what is in my mind very clear in the question of this session about incentives is also the question of cost. To ensure data quality at the source implies a cost. And the question is, who is going to pay for it? So with this in mind, I would like to go into my talk and perhaps, could you point me to my, oh, there. Thank you. So let me project here. So in my talk today, and I think I have about 10 minutes, I would like to share with you some insights from some initiatives at HL7 Europe that will explain our thoughts and our standing on how standards, and in particular HL7 FHIR, can impact health data quality. So a little bit about HL7. HL7 has the vision of a world where everyone can securely access and use the right health data when and where they need it. So it's very much about at the core of this conference. And HL7 has created a number of very successful exchange standards since 1986, starting with V2, which is running in pretty every laboratory system, and more recently to CDA, which dominates the cross-border exchange of data and My Health at EU, and more recently HL7 FHIR, which is about defining the interface, defining the data we share, and giving the opportunity to also establish contracts that convey the information that is shared, and perhaps also some stringent requirements about quality of the data. So what I like, and I think it made a huge impact on me, was these ethical principles that were introduced by the French presidency 1 year ago. And I'd like to briefly use them to frame this discussion about data quality. I think I lost my slides. Yes. Okay. Good. The first one is about the humanistic values, right? Okay. And how digital health complements face-to-face consultations. The second one is about the right of individuals, what they can do. Things like who is using my data, for what purpose, when. I allow people to use my data or applications for my data, or I disallow. And then being inclusive about accessibility, taking into account the needs of people in terms of challenged individuals. And I will come back to you on that when we talk about drug labeling and EPIs. And also ensure that they have the training. And this applies equally to the people that are creating the data and the people that are using the data. And lastly, a quite interesting and forward-looking aspect, the eco aspects, digital and green e-health. So the second point that I would like to use as framing is the basic principles of European health. The first and foremost is patient safety and privacy first. The second one is the trust, maintaining the trust between institutions and the people. And the last one, take into account that nations, European member states, have their own processes. And there are several regulations that underpin this. One of them that will be the topic of my presentation today is the European Electronic Health Record Exchange Format and the underlying standards. But there is the Strategy for Data, the AI Act, the Data Governance Act, and of course the upcoming proposal for a regulation on the European health data space. Last but not least, the NIS directive on cybersecurity. But let me move on to discuss the first point that I would like to make, which is about the European Electronic Health Record Exchange Format, and for the purpose of this discussion today, how it relates to data and data quality. Yeah. So the Commission, in its recommendation in 2019, it said, go out and create standards and specifications for the exchange of laboratory data. That's critical for COVID, even if it was before, and the CDC, for instance. Go there, create a specification for imaging data and the reports. Go there and give us discharge reports for hospitals. Go there and give us patient summaries for rare disease so that we can actually benefit from this huge amount of people that are in Europe, 500 million. we can have people with rare diseases there, even though it's rare at the national level, and then fix the problem with the prescription and dispensation. So this is what they asked to the XE-Health project, which worked very closely with the health network and its structures. And then there is the European Health Data Space, which came later, and we need to see where these two meet. I hope that we will see more about that. But the key issue here is data quality. And my message here is that we need to solve two problems. The first problem that we need to solve is the problem of terminology, because all of these standards kind of solve the problem of structure, you know, how the message that is exchanged is structured. But what about the values inside? This is where we have problems, and we have problems even if we use a very well-established terminology like SNOMED, because there is the element of culture. And you can hear people in the UK they use the read codes initially and then move to SNOMED, where different institutions, because of the culture, they use a different part of the terminology. And that creates problems when you aggregate data. And we will hear more on that from WHO. So we need to pay attention in the language and the culture. That's my first message. The XE-Health project had a very lofty objective. It said, we need to collaborate. We need to create communities of practice. And we need to recognize the role of digital inclusion in skills high quality. And we created a lot of data there for standards. We created the templates of XE-Health that are in Articore, and you can find them. And you can discuss them and exchange information and questions for that. It is important to have a community, a learning community that continuously refresh and is part of a standards ecosystem that is not different from a digital health ecosystem. The second point, quality at the source, we said terminologies. The second point is change management. I already mentioned that in the beginning, HS7 worked with HS7 v2. Then it had CDA because it rode the wave of HTML, of the browsers and so on of clinical data. So we had forms, we had clinical documents. And this is how now in MyHealth@EU we exchange data on prescriptions, on patient summaries, and so on. But people want HS7 Fire. And why do they want HS7 Fire? They want it because it's cheaper. This was actually the means that made HS7 v2 a success, and it comes back in HS7. It's cheaper, it's predictable. We can understand what is the cost of implementing a standard, so providing data. And this is, I think, key and an element that we need to take into account when we talk about data quality and incentives. We can create quality data, but to do that, we need money. It's costly. Think of a doctor that is registering information. Yeah. In order to have this information become multi-purpose, it has to allocate to it a very important amount of context. And this is heavy and this is expensive. But XE-Health did take care of the issue of change management. And we did an amazing work even beyond the actual contractual obligations to make sure that the HS7 CDA specifications and the HS7 Fire specification both were coming from the same logical model, the same concepts, yeah? So even if we used a different way of representing this information, the information remained the same, and this is where the changes would happen, yeah? The second thing is the community. The third thing is the community. I mentioned the second and the first earlier. And here we actually create a pledge for people to support the electronic health record exchange format. And I think this is key in making standards work. We created a lot of hackathons for rare diseases and for chronic diseases. And I hope that we can continue with a larger community to support that idea for the electronic health record exchange format as we move forward. We have different pledges. And this, I hope, would outlive the Crossy Health project. So this is one particular aspect. How do you actually capture data and share this data in a format? The second work that we do is on drug labels. And actually, this is for me a fascinating idea because it builds on the electronic health record exchange format. How does it do that? Well, we started many years ago with the patient summary concept. What is the patient summary concept? Each one of you takes or doesn't take medications, has or doesn't have some conditions, and has some health goals, right? So these all you can capture in a patient summary. Now, when you look at the leaflet, the inset of one medication or the product label, for instance, you go to a pharmacy to get medicines for the headache that you have, right? The information there is generic and pretty much legalese, right? What if you could use your personal profile? And profile is a bad word for AI, you know that. But what if you use your personal information, your personal lens, that's what we call it, G lens, the gravitate lens, your personal magnifying glass, yeah, to actually see the label. And in fact, a magnifying glass would be quite useful because these letters are quite small and are smaller. I was speaking to some people that are printing these labels, and they have a lot of trouble working with paper and making it fit in the box. So they make it smaller and smaller, and in the end, nobody can read it. But in this case, we have digital health, and we could, given that we have good data, actually magnify the important information for that. We could even, in my vision, go further and have like your app going through the different NSAIDs and select the one more appropriate for you. So this is what we wanted to do. And this is a big EFMI project where we are working very hard and in collaboration with EMA and hopefully also FDA and the PSDA, which is the Japanese version. We are creating lots of applications, but I don't want to get into that. What I would like to get into is the standard and how important it is to have a quality standard that can work across the world. So in Europe, the EMA has 4: substances, products, organizations, substances. Yeah. So these 4 elements create databases. I forgot referentials. Substances, products, organizations, and referentials. Referentials are the value sets, right? So they have this information to support all the different functions that relate to data, pharmacovigilance, marketing authorization, so on. But this information is not available around the world. So what we did is we took these elements from the specifications of EMA and we said, let's add to that the information that is missing. The information about the product, the information about the substances. And that's the way you create a global standard. And we are testing that. We are testing it with SPL, which is the standard in FDA. We are testing it with the XML standard in Japan. And that's, I think, amazing because what we do here is that we are establishing a language. We are establishing a common culture for the standard to do what they are supposed to do in the information age. So that's my second, third, fourth probably point about cooperation. So to support this new mentality, which is standards as infrastructure for innovation, HR7 has changed itself. Yeah. And what change has happened to HR7 globally is we are supporting more and more the concept of accelerators. And accelerators is about working with the users to create these standards. And what I told you about the collaboration with EMA and FDA and PSDA, the Japanese, happened under one of these accelerators, which is called Vulcan, and it is about clinical research. So there is a route to create high quality data. And that's about understanding and learning and exchanging information. Yeah. So I know that I'm running out of time, so I would like to highlight what's ahead. So one thing is more work at the international arena. Another part of the work is working at the European arena. And right now, as the XXIX project is ending, we are looking at the next project funded by the European Commission, which is called Expand the AIDS. And many of the partners here are present. And one of the important topics there is quality of care, certification, support for the European health data space, creator of what is called XXIX, different groups. One is for standards, one is for different ecosystems, so that we structure a larger infrastructure of people that are capable to drive data quality. HL7 Europe in itself is doing one of these networks, and this network is Hospitals on Fire. And here we want to know more about how people are using the data. Remember what I said in the beginning, we need incentives, and there is a cost. And this cost of creating high quality data is probably the elephant in the room. Yeah, how, who is trained to do that? We are talking a lot about data science and research, but you need the data to do that. So who is creating the reliable, high quality data? Who is paying him or her? Yeah. So we have the standards, but we need to use them. Yeah. So workforce is critical. Yeah. We need to be able to train these people, and I'm glad for the International Masters of Digital Health that was recently also acknowledged and accredited by EFMI. I think the different institutions need to pay attention to the data work. There are a lot that people that engage with the data quality need to do. And training and reskilling on standards, interoperability, and data quality are paramount. So from an HL7 Fire perspective, it is important to establish this common language and challenge the status quo. It is also very important to create a level playing field for experimentation, friendly to extension and instrumental to evolution. And that's where we see a network of standards organizations playing a huge role. There is also the aspect of maturity and management of change, because nothing remains the same. And I like the title of the conference, which is Dynamic Complexity. Even if you take a picture today, the data is different, right? So how do you deal with quality? This is something we need to be able to understand and cope with. From an HL7 Fire perspective, we have the accelerators, and we have an environment where we can create and share information about implementation guides. We have sandboxes where you can test and you can play with the data so that you can develop the concepts and the competencies that needed to deal with that. So these are my key messages. And if I may highlight one thing, data quality is at a cost. And we need to understand what incentives are there and who will pay for this cost. And in the end, what is the return of investment? Yeah. Thank you very much for your attention.
Thank you, Catherine. Again, please start taking notes on the questions, and then in the end, we'll have an opportunity to discuss with you. Now we are moving to Robert Jakob, that I think it's online. Robert is the team leader of classification and terminologies in the WHO. So, hi, yes. Robert.
Hi, hello. Thank you for this invitation and giving the opportunity to talk in an arena where normally WHO is totally forgotten, and I've seen this in the earlier presentations. So let's have a look at ICD and the WHO family of classifications that really is a cornerstone in health information, and that has been around for quite a while. The classifications and terminologies is a mandate of WHO. We were just hearing about, oh, let's work together on terminologies and standards. Well, WHO has been asked to do so and has been doing so for statistics, for epidemiology, for data analysis, for standardizing of nomenclature, and has done so for the past many years. And the requirement, on the other hand, that we have from a WHO side, so that everybody can use our products, is that this kind of information standards are an open international public good with free access, free of charge for all users. However, agreed, somebody has to pay for this, needs to want to pay for this to some extent. Well, we have the WHO membership for this in order to make these things happen. The other thing is, of course, always the question, why do you collect information? There was a person, it was Mr. Wingert, who standardized SNOMED some 50 or 30 years ago, who was saying a data collection without a purpose is a useless data collection because you may be missing a variable that you are interested in. So let's think on why do we encode content? Why do we have highly structured content at all? Then the other tools need to be multilingual, the standards need to be evidence-based, and there should be collaborative, reliable development and reliable maintenance. Now, ICD is one of these global information standards, and I'll show later. Unfortunately, ICD is always put in the corner of some kind of sclerotic skeleton for some crazy statisticians, but this is no longer the case. It has really changed with the ICD-11. And it is concerning to see that information infrastructures are built in high-resource countries, looking backwards on ICD-10 and rather looking forwards on modern technologies like 11. Now, ICD is independent of language of culture, is an international product exactly as required just now, and it has been made clinically relevant and scientifically updated. It is an integration of terminology and classification by mere needs of using it in an electronic environment. And don't forget, it has been around for 150 years. And while data were still transported with paper and later on diskettes and now electronically, it has been there for data recording and reporting and analysis. Now, when we look at what areas of data are covered by WHO needs for national and international reporting, we see here a whole chunk of big ones. That's the big wave. Then we see a little bit smaller chunk. These are the kind of health-related, health financing, health resources components. And then we have something that is put a little bit on the corner that is something more futuristic, where we have to see whether these desires that are currently existing can be fulfilled. But one thing is important to make sure that somebody who's providing health documents things only once, and that's where we are talking about interoperability. Also, I have to say, I don't like this word very much because it doesn't mean much in the end. Now, while developing, for example, ICD and also the WHOFIC, we looked at some core use cases. And yeah, we have cause of death reporting in place with a lot of context. We have all these other use cases without mentioning them individually, ranging from clinical documentation until primary care. We have rules for recording. We have minimum data sets formulated for the use cases. We have rules for coding, rules for reporting, and even diagnostic and therapeutic algorithms that are currently in the process of being stepwise digitalized with the accelerators. And it's a little bit scary to see that essentially things are reinvented, and I'm not sure whether the initiatives that were mentioned earlier are taking into account these existing recommendations by WHO. Now, we have to balance certainly the need for information at an individual level with the needs of information at a public health level. And this is what this picture essentially tries to convey. However, when we talk about public health and large-scale statistics, and even for the detailed, things need to be stable. They should be understandable across countries, reliable across countries. They should be medically scientific sound. And there should be, on the other hand, frequent changes when it comes to the scientific detail in the context. And there we need to balance the needs, that is feasibility and the time stability, and across these settings when we talk about information standards. For good reasons, the handbooks of airplanes are written in SGML, a markup language that will allow it probably even in 50 years to understand what is in the book, and because it's plain text description. Now, what impacts the quality ICT coded data? So most importantly is whether the data is complete that is reported, where we have age, sex, maybe specific complete diagnosis, or for causes of death, for example, non-fatal conditions like wards. And on the other hand, contradictions between age and illness and age and death. And the other thing, of course, for data quality is always the timely compilation and the useful presentation of the data. Then impact on comparability of the data is really diagnostic culture, the understanding of diseases, the goals of the data collection, the circumstances the data are reported, the coding practice, the rules for reporting, and also the translations. And I'm just showing here an example. In that case is some cause of death information, several years, different countries. And you see there in the middle a peak of frequency for deaths by muscle wasting and atrophy, and similar countries that are also in the list never get to this level. I'm not disclosing the country because that's not the point to put anybody on the spot, but you can really see that there must be a different understanding of this disease that leads to this kind of information. Now, on the other hand, we have also systemic impact on data when it comes to statistics and coding. And we see here, for example, broad differences between, let's say, mental diseases frequencies in one country and the other, where you say, we don't believe that the people are so different. And these are hospital data that have been standardized following a European project several years ago, and that were showing that even in morbidity context, if it comes for the data analysis reason for encounters, the comparison is not easy, if not to say nearly impossible. Same for other diseases. You see this here, broad range differences for countries where you say, we don't think that the population is that different. There must be something else that is biasing the information. Then we have something that really affects the individual information. We have a WHO guideline for definition of hypertension. This is wonderful, and you would expect that the world is wonderful. But what are we transmitting in interoperability if we then see that highlighted here in blue, for example, the threshold values for hypertension are eventually slightly different between countries. So we will have, in that case, this the American Heart Association, many more people with hypertension than in other countries. And if you get the individual file of a patient with hypertension diagnosis, it may turn out that maybe in another country, it's even not considered a hypertension grade 1. We have other things, of course, when it comes to the quality of information for use, for example, in a context of research. We have here an example coming from the International Collaboration on Cancer Reporting. They have defined forms, reporting forms for the data so that they are interoperable and can be used in different sites with all the information necessary. There are specific forms for different cancers, for different sites. But what we see here also, we have 6 pages of reporting form and 26 pages that have definitions, descriptions, coding, literature, and other things, so that we can be sure that the documentation is really done in a comparable way, so that the information is truly interoperable, not only technically interoperable. We have the reality that says the poetic richness of the medical language with all its nuances never can be easily processed by machines, or maybe yes. We have many terminology systems. Some are huge, others are small. Maybe they should be linked. And the other question is certainly, would we look at natural language processing instead of drawing on complex terminologies that are too big or too small? Now, then there is a data provider impact. And that is what was mentioned earlier also, I think, in this session, where we say data input is in many places dropped on the health workforce. Health workforce have no time. I'm at the moment in a meeting in another part of the world, and there was the mention a single doctor sees up to 200 patients a day. How should this person provide input in an environment where patient documentation software is utterly bad designed or badly translated, with the result that in some countries the productivity of the health workforce dropped. In another country, physicians are trying to leave the capital city because some software has been introduced that is taking more time than the patient treatments. And then we have, of course, the backwards looking ways for coding, where people still insist on drop-down lists, loading tables and other things for coding, things that is a nightmare for the quality of the data, as well as for those who have to provide input. And last not least, when we talk about the quality of the input, is to say, if you input data into some system and you never get anything back, why would you care about this? So data feedback is important. What did WHO do to address many of these issues? Not all can be addressed easily. We built the ICD-11 as a system that has this integration of terminology and classification and the clinical detail. And what we're seeing in places where it is implemented, that the motivation for documentation is becoming high because coding is easy and you can find the clinical detail. I'm not going into the figures. And just to show the comparison with ICD-10 in the corner, ICD-10 is a totally different animal of a different century, nothing to be compared with this. And based on this system, of course, we have preferred terms, synonyms, as well as the language translations with their synonyms attached to it, so that we have a truly system that is easy to use, that has a REST API, so it can be plugged into softwares. We have software samples on GitHub, and we are working on a FHIR API to satisfy the FHIR community. And they can access all of this online, and here is just one example of a coding where the system has support for multiple code combinations, and you can see here it's coding the disease and the laterality in a place where this has been implemented. And the whole thing is multilingual. Here you see an English, Spanish version. I was looking, the Portuguese is not fully ready yet, and we will have 20 more languages at that level of detail available for diseases, but much more than diseases. ICD has external causes of injury, war components, it has sites, it has buildings, it has parts of buildings, it has devices, all the things that you need in the context of injury, of external cause or disease. It has a list of substances in line with the international non-proprietary names that are produced by WHO, generic names. So there is a tool that is there, and this is all what we call the WHO family of classifications, where we have the ICD, an interventions classification, a functioning classification, all now on the same platform as I was showing for the ICD, with similar levels of detail. And then we have linked to this system, embedded in the system, codable access to your unique API, the generic names, INN, a WHO device list that is being worked with in collaboration with the European Commission. We have the tissue types of the tumors, we have anatomy as produced by WHO, severity, infectious agents, vaccines, and also we are working on links with other systems that are used in other places for reasons. So giving this, of course, I can only respond to my previous speaker that, well, we are having this international collaboration. Please collaborate with us so that we exactly have this common language for health information. I make a summary here that was made by Alan Rector in 2015. So let's learn new techniques. ICD-11 is a step forward in this kind of context, but make human-centered design central at every stage of the process. And we can certainly explore big data and other techniques, but we should not fall into a trap of the hype, but rather know that there is still a lot to learn there. With this, I come to the end, and I just say again, record ones use multiple times for best possible health of all people, and join our family of classifications and terminologies so that we work together and we don't create parallel systems. Thank you very much.
Thank you very much, Robert, also. I think we are, again, moving to the next presenter. Now it will be Steve MacFeely from the WHO. Again, from the WHO. MacFeely. Sorry.
So, good morning, everybody. It's always very hard to follow Robert. He's a very compelling speaker. So what I want to do is take a step back and kind of put some of what he was talking about in a broader context. So I joined the WHO about a year ago. I'm not a health specialist. I'm a workaday statistician. So I've been looking at this kind of issue of interoperability from the perspective of many sectors over the years. And that's what I want to talk about, is kind of really looking at health from a broader perspective. So before we get into interoperability, a lot of you are health specialists, so you like diagnoses. One of the first lessons I really want to stress is when we're talking about interoperability or seamless, networked, joined up government or joined up health, you can only do this if the data are joined up. Time and time again, I've seen these issues being discussed as IT problems with IT solutions. I would just stress that I disagree fundamentally with that. We need to think about data as an issue in itself, and data need to be organized. The architecture needs to be organized. Then we talk about the IT. So I think in a lot of cases, we put the cart before the horse, and that leads to a lot of the problems that we then deal with for generations afterwards. I've quoted, this quote is from a paper that I wrote. This paper was actually, it was like an open letter to the Irish government about how to design an interoperable system in Ireland, like really looking at organizing public sector information in an organized way. And I think most of what's in this paper, even though it's specifically written for Ireland, really kind of, it applies to almost any sector and almost any country. So how do we achieve networked or seamless government? Well, first and foremost, I think we need to start thinking, we need to start taking data seriously. Data in the digital world, in a digital economy, we are talking about data all the time, whether we realize it or not. When we're talking about machine learning, when we're talking about artificial intelligence, anytime we use the word digital, we're actually talking about data. So it's this massive cross-cutting issue, and yet it's not taken seriously. I think it's not understood by a lot of governments. So before we get into the mechanics, what we need, if you look at the green hexagon at the top, we need good data governance. People need to be reassured that their data is being treated with respect. It's been treated, if it should be confidential, it needs to remain confidential. So we need safeguards in place to do that. So kind of the legal legislation is really important. From a statistical point of view, you have a National Statistical Office, but then that statistics office needs to be able to integrate with all of the other parts of government. And that's really important for the flow of information. The same will apply to health sector. We're talking about really sensitive information. There needs to be good governance in place. Secondly, if we look at the orange hexagon, we need to think about data now, I would argue, as infrastructure. So just like everything else, you need good architectural design. If you want a proper functioning house, a proper functioning building, you design it carefully. Information systems require the same amount of effort and respect. And what we're talking about here is unique identifiers. We're talking about international classification. So you heard about HUFIC a minute ago. So ICD, ICHI, All of these classifications exist. So rather than inventing new ones all the time, why not use the international standards, adapt them to national purposes if you must, but use common classifications across all of the data sets, use unique identifiers across the data sets. Now, when I say this, I should say what I'm arguing here rests on a number of hypotheses or assumptions. First is, if we want to make good decisions, those decisions should be informed by information. If you disagree with that, then you're probably going to disagree with almost everything else I'm going to say. Secondly, those information, no, put it a different way. We all have an expectation that we want our government or health sector to be efficient. These are the demands that we expect. I would argue, if you have that expectation, there must be a trade-off or a price to pay. So we can think of it as cost, a financial cost. I would also argue there's a cost for us personally. And this is the trade-off between the collective and the individual. We must be willing to supply that information to the health sector, to government, in order to allow them to make decisions that are informed by data. And what I see in a lot of countries, and where I came from in Ireland before I joined WHO, we have this expectation that we want efficient government, we want an efficient health sector, but we don't want to share our information with government. And to me, that's an unrealistic expectation. There is a price to be paid. And if we're not willing to share our information, then I think it's unrealistic to expect efficient services that are informed by data. On the blue hexagon, institutional coordination is critical. And we spoke a lot about this yesterday. In fact, we had a fantastic speech by our chair, our chair today. All information is contextual. Secondary information, administrative data, they're invented in a time and place. And that time and place is changing all the time. So if you're using those information, you need to liaise with the data custodians, the data stewards, and understand the origins of those information. What was happening at the time? Because in a lot of cases, just as Robert alluded to, and you saw there, there's strange things happen in the data. And it would be very unwise, I would suggest, to take those data at face value and draw conclusions from them. So you need to go back to the owners and understand what happened. But you also need to be forward-looking. So you need to work with those data owners to show them that when they do things, I give you an example. I mean, I worked for a long time on business registers, and we used to see these spikes in business ownership. And in a lot of cases, that's where there was a long holiday, there's a public sector strike, there's something happens, and then all the enterprises are registered on the same day. But in fact, they may have been birthed over the previous 2 or 3 years. These things have an impact on the data. So it's not just being careful about using the data, it's actually working actively with the custodians to make them understand and incentivize them to help them think about the data as an asset, as something that they really need to work carefully on. Another issue, just as a bit of a distraction or a bit of a sideways high roof, but a lot of what we're talking about with secondary data, and this will apply to health data too, it began as public sector, and now increasingly we see sectors being outsourced. It's very important, I would argue, if we're outsourcing former public services to the private sector, that the private or the public sector retain ownership of the data. What we're seeing now is, as services are being outsourced, those private sector companies are then selling the information back to the public sector. And that's really inhibiting research. It's really inhibiting informational flow. And I think these are things, when we think about changing systems, we need to think about the implications on the data. Yeah, so to conclude then, just to come back to a point I made a while ago, I think not just in health, but in other sectors, we really need to have an adult conversation about the trade-off between efficiency and privacy. I would argue different countries will be on different points of that spectrum. but we have to be on that spectrum somewhere. That there's a price to pay, and I think there's a lot of unrealistic expectations, and I think that stems from as well maybe differences in our views between collective and individual health and well-being. So I'll stop there. Thank you.
Thank you, Steve. I think we can now open for discussions. So I don't know if somebody wants to make a first question to this panel. And also online, Paulo. So
I'm striking online.
okay. So not yet. Apparently, everybody was very clear. So no doubts. Okay.
I do have a few. One professor, I forgot to name the leader of PhD will say
Catherine.
Catherine.
The first would be with regards to security. I did the initial 7th fire course in December. And what are the restraints of security? Some of they were briefly mentioned during the course. Like, I mean, players that are buying for the system, how do they restrict secure? One of their main concerns. One of their main concerns was definitely one of their main concerns was security initially by third parties accessing the fire data. Is that something that is completely addressed? Is that something that you can sell to new buyers as being the issue dealt with? And also the cost. You mentioned cost, but you never mentioned how much the institution will be saving, for example, right? That's the incentive, right? The cost is lower, but how much lower? How much the data collection and data exchange and data storing would benefit that institution if you're trying to sell it to an hospital, to an investigation research team, to whatever? And since I have you, also the second question for Professor MacFeely. Sorry, 1 second. I'm actually doing a master thesis with Professor Ricardo as my mentor on data standards in investigation centers in Portugal. Right now we have 23. We're still going to start in January collecting the questions and collecting the answers and whatnot. But one of the main issues is nobody has really any idea of the different institutions. In Portugal, we have 23. Originally, I got incited to do this master thesis based on the European data, the health data space, and nobody knows how institutions are storing different data, even like what kind of data are they using. And for example, the R part of the FAIR process is always going to be tricky until we actually have a European-wide or even worldwide way of sharing information. It's not going to be reusable for most institutions if they're storing it different ways, if they're collecting it different ways, that they're not sharing with each other or with other institutions. Most of the investigation centers they get from the hospitals they're associated with, and there is no actual sharing between them, right? Unless you know somebody or you have a friend here or there that can give you some more data, right? How can we fix that problem as well? Thank you.
Thank you. You can answer slower.
Yeah, I can answer a little bit slower, but many thanks for your question. Let me answer actually these questions together. If I understood your question, to repeat it also for the audience a little bit slower, you asked fire and security, where do they stand? And cost and fire, where do they stand? So let me take these together. The most important thing about fire, which took the world by fire, is that it wasn't anymore an esoteric health sector standard, but it was using the infrastructures that we every day use, like the internet, like SOAP, like GET and PUT. So it was structures that were there, which means that you did what you do in the API world, in the application programming interface world. You externalize costs. So many years ago, cost externalization became the norm in what we call platforms. And you can name Facebook, you can name Amazon as the leader there. So you externalize cost because you say to people, here is the interface. Here is my door. We can have a contract and we can use it. And you can use this door to develop your own innovations. And you can help me also meet your needs. Yeah. So it was a kind of a collaborative negotiation about services to be given and opportunities to innovate. Yeah. So in essence, the cost is part of how big this interface is. And it could be measured in transactions, or it could be measured in interfaces or resources to use fire speeds. But it can be associated with the services provided and the return on investment. So we need a framework there. And I think this framework will actually answer the question that we are having in our hands, which is what are the incentives for data quality? Because the higher the data quality that you provide, the higher the return on investment, right? So you will be able to absorb the cost. The same thing holds, and I really like your ending statement there about efficiency, yeah, is about security. Security is also externalized in fire. We have security in the form of a oath as a kind of a default, but then depending on what is at stake, you can have different opportunities to employ security aspects. For example, I can also refer to security as a dynamic surveillance, right? So you not only have some doors and some keys, but you also have sentient entities that monitor who is doing what, yeah? So security, for me, is an infrastructure property. And we can be as serious as we wish with that, as we are for privacy, but that does not come freely, but at a cost. I hope I addressed both your questions, yeah? Okay.
I really don't know how to answer your question. The implications of what you're asking are really far-reaching. I'm involved in work at the moment at the UN around international data governance. So if we start with the international flows, that in itself is a really complex issue. Because you can look at data flows from a number of perspectives. So for example, at the moment, the World Trade Organization are looking at data flows from a commodity perspective. So they're looking at commodifying data. From my point of view and from a developmental point of view, data are much more than a commodity. So the idea that we would regulate data purely from an economic commodity perspective is really worrying. So that's one thing, and that creates a lot of disincentives because, you know, a lot of people then don't want to share data because they think, well, if I transmit it to a jurisdiction where data protection is loose or non-existent, then, you know, that data could end up anywhere. So the international aspect is really challenging. But even within the country, I mean, the point you make, I think applies to every country. I mean, despite all of the information that's sloshing around, we don't know a lot of the really basic stuff. And I mentioned this yesterday. I mean, there's all of this complex work going on within the health sector. And yet basic births and deaths remain an enigma for large parts of the world. And within each individual country, there'll be pieces of basic information that you'll be scratching your head wondering, how is it possible we don't know the number of institutions or what data they hold? It's not unique to Portugal, I'm afraid. It's everywhere. I mean, what we do about it, I don't know. Part of the discussion is back to my main point, is actually taking data seriously, helping governments to understand that if you think about the future economy is largely services based. I mean, an awful lot we do involves the movement of data, whether it's trade, whether it's downloading Netflix, all of these things, whatever we're doing, purchasing Uber Eats, it's all data. And if we kind of just leave it unregulated, if we leave it loose, I think we're really I think we're allowing huge systemic risks, not just for economy, but just our own protection, the future of our own freedoms. So maybe avoiding the question, but I think the first thing is just trying to elevate the topic of data and making people understand that it's a really, really serious issue. That, in fact, somebody yesterday put up the emblem for 42, the life, you know, from Douglas Adams, The Hitchhiker's Guide to the Galaxy, and I think that's the challenge in a way, because if you think about the second book in that series, it's called Life, the Universe, and Everything, and That's what we're talking about when we're talking about data. We're talking about life, the universe, and everything. It's pervasive, it's ubiquitous. So everything we do is being impacted by data, or we're generating data. And it's a huge issue. And yet somehow I don't think it's been taken seriously. So I don't know if that even begins to answer the question you asked.
Do you think that incentive of actually being able to use other research departments or other institutions data would be enough for people to try to converge to certain standards of use? And by the way, yeah, Professor Ricardo has mentioned that a few times. I'm actually reading the Restaurant at the End of the Universe now. really good book series.
Yeah, well, I mean, I see within the research community, there's movements now towards, you know, in order to publish, you have to make the data available. And I think that's probably a good thing, but that's back to governance again. We have to make sure that that's done in a proper way. I mean, it's a big challenge for us. We're now about to launch in the coming months a World Health Data Hub, which is a portal for making all our statistics available in one place. There'll be a data lake sitting behind that where we can store a lot of really sensitive microdata. And a big challenge is how to regulate access to that, because every piece of data, every data set's bespoke. The conditions under which those data were collected will vary from data set to data set. And the terms and conditions on those data have to be respected. And that's a really challenging piece of governance for any institution, including WHO.
Thank you.
We have questions here also in the room.
Okay, maybe we'll just.
Thanks. Question to Catherine. My name is Ravi Shankar. I work in WHO. I support the GIS Center there. About the FHIR and HL7. I know that we had been talking about this internally within WHO, also with our colleagues with the digital department on this. The aspect of geography in FHIR is key because we have very set standards for our, we call it as OCG, standards for geospatial transactions of data between, it has been industry standard. Open geospatial standards are already available. That's how we transmit through a REST API or through transactions for including satellite imageries or admin boundaries, the names of the settlements and things like that. So how do you, from your perspective, you feel that should we move all our data into FHIR HL7 standards, or still we can maintain there and have interoperability? Yeah. I don't have an answer because I also got introduced to FHIR very recently, might be 2-3 years ago, and we are trying to figure out our way with our colleagues to see to have an amicable solution for this. Thank you.
Yes, thank you for this question. I think I alluded to my previous answer. There is a big movement worldwide, which is the API movement. The API movement is the movement to create application programming interfaces. So rather than giving access to a database, give access to a slice of the database that we control, so that we separate the part of the backend from the front end. So in the backend, you can change everything you like, as long as you maintain the interface, yeah? So this is a way also to deal with legacy systems and so on. So HL7 FHIR, pretty much like CDA was a child of HTML, is a child of APIs, is a child of this movement to talk about the interface. I know there is a lot of talk about creating databases and based on FHIR, but what predominantly FHIR is this contract about the interface. And the different accelerators that I showed in my talk are ways of taking specific use cases that are real world use cases into FHIR, yeah, introducing implementation guides, introducing sample anonymized data to play with, and accelerating the process of jumping in on FHIR and delivering services that work. And most importantly, something else that I didn't say a lot about, but I think it's paramount, is maturing the standard. So accelerators are incubators for maturation of standards. So for example, taking back the geographic information systems work, I know that there has been a lot of work with health and geography systems, for instance, showing the development of an epidemic, right? Things like that, or geolocalizing COVID instances. I'm not sure what exactly the developments that relate to fire is in this space, but I could certainly see this relating to the public health accelerator that is called Helios. But I would point you to go online and check that Helios accelerator and see to what extent it can support your needs.
Thank you.
Okay. I think we have two questions from online. Maybe Paulo, we can say both.
I will. Now we have more. So thank you for these great talks from Pedro Silva. Thank you for the presentations. My question is general for anyone who would speak. How can the increment of data collected be a problem in terms of storage and data handling? You want me to ask the second one?
Yeah, maybe Paulo. Yeah.
The second one is hello to all of you. It's from Tiago Santos. The question is it true that we need an open access platform with trusted digital health information to be accessed? And I think it will be the way it will be implemented won't digitally be a problem from the point of view of comprehensiveness for all citizens. That's one question. I bring this because, for example, the non-digital generations will have difficulty consulting. Do we need to create mechanisms that will overcome this obstacle?
Okay, Paul, I think I'll use...
Still the last one from Carlos Parra-Calderon. In the context of genomic research with personal information of all... Oh, sorry, this is not a question, it's a comment.
So I think I'll use my moderator role and ask Carlos to tackle the first question, and Jakob, if he agrees, on the second one related with how patients actually, if they understand or not the information. Okay.
I start?
Yeah, Carlos, go ahead.
Yes, one relevant challenge is about the sustainability of the continuing data collection in the context of health, because, like you say, increase exponentially the level. I think one solution to work on data handling, this kind of solution born in the context of ethical and legal aspects related to data protection, but maybe will be also one solution for this kind of challenges. It's about federate data. It's how a lot of solution now in Europe, for example, European Health Data Space developed the strategy in with focus in federate data, and maybe the industry develop new solution, new tools, new how can distribute the data to make this possible, because at the end we will need all time more servers, more hardware, more needs to support the data handling. But I think this is the solution born in the context of data protection, but can solution this kind of needs.
Okay, Carlos, thank you. Robert, Jakob, do you think you can answer the second one? Thank you.
Well, the second one with digital not savvy people not being able to access the data is certainly a point. And there are two things to this. Number one, we have people of every age, including very high age, that happily use electronic tools like their smartphones or tablets or small computers to access information online. And the second point is, I think we are not talking about presenting raw data exclusively for everybody, but some analytics that are known that they are in the core interest of people. But I would also defer there a little bit to Steve, who essentially was mentioning the World Data Hub. that is one of the instruments that does not only collect the information, but it will also allow to output information in a way that it's digestible besides other means. Steve, would you like to join in there?
Yeah, thanks, Robert. So one of the things that we have deliberately tried to do, and in fact, it wasn't specifically age, but we have put a lot of efforts in to make sure, for example, that disabled people with different types of disabilities can access the World Health Data Hub. And in fact, we've invested a huge amount of time in that. The age thing, I think is always a challenge. I mean, look, I've elderly my parents myself, and I have a father who's embraced technology, and I have a mother who resisted at every opportunity. And no matter what we would do to the World Health Data Hub, my mother would resist. So there's only so much you can do, but you know, generations will change. But I think the fundamental point is we are trying to make all of the information available as public goods. And that's the critical issue. As Robert stressed, one of our core mandates is to make everything available to everybody free of charge at the same time, without any favoritism.
Yeah. I would like to raise this topic as picking up the public good. And we have thought about the patient summaries. Remember, when we are talking about electronic health records, we are thinking of the hospitals, right? Yeah, they maintain the records. They are called medical records officially, but they were extended to cover outside the hospital. They use the term electronic health records. And we said, okay, let's find something that can follow the patient, like the patient summary. And I think it's critical now to see this patient summary as a public good, because this will make a very important shift in our culture, mentality, and thinking. This will make us more data literate. And this has nothing to do with technology. It has to do about data that are yours and follow you. And you make decisions based on data. By inbreeding, in making this part of our culture and our thinking, I think a lot of actions will follow at different levels.
Thank you. And one last question, or two. Okay. She has a microphone, so I'll.
I think it's fine. Hello, I'm Josefina. I'm studying in the Master of Medical Informatics in Porto with the Professor Ricardo. And thank you very much for sharing your experience. And I have two questions for Carlos and Catherine. The one is with possibilities does nutrigenomic have to be incorporated in public health or HL7? That's the ones. And the second, everybody talks about personalized health. And my question is, what is more expensive, personalized health or public health? Because if we haven't money, what are we going to do?
I didn't understand the first question. I understood the second about the gap.
Yes, I asked which possibilities have nutrigenomics to be incorporated in personalized medicine and public medicine for everybody.
Yeah, no. Maybe Carlos can answer the first question. Huh? It's very close to you.
Can you hear me?
Yeah, sure, Carlos.
Okay. Yes, in the set of standards we managed to apply in precision medicine research in Spain, of course, we will apply FIRE, and now we work with FIRE and to align with one new standard to ask questions related to genomic information. This standard is Beacon. Beacon is one standard developed by Global Alliance for Genomics and Health, and in fact, in the context of impact, we start and analyze the possibility to develop one implementation, FIRE implementation guide to apply beacons in we start the first exploratory study. We don't connect formally with HL7, but I think we soon will connect it. With other hand, we also explore the possibility to apply the OMOP on Fire initiative, and how can use Fire and OMOP data model to in the context of our in this OMOP more oriented for clinical information, but Beacon is specifically for genomic information. I can share information about this.
Thank you.
Yeah, on the topic of public health and fire, I would like to say that the recent developments with COVID made public health more real time. Yeah, they actually increase the granularity of the information. As they become more granular, it also has a stronger link to clinical informatics, to healthcare. And I think it is an important change that we need to foster and cultivate further. And to that effect, I think HL7 Fire can be a catalyst.
Thank you, Catherine. And the other question?
Dear Chairman, thank you for taking the question. My name is Krastev. I'm professor at Sofia University, Faculty of Mathematics and Informatics, and want to make a short comment about what we witnessed today and yesterday, actually. In my opinion, in some of the lecturers consider data as in too abstract terms, while data is always concrete. Second, we have raised the question on the issue of the value of data. Data indisputably has real value because it's used for decision making, and a lot of companies actually don't agree to provide in the private sector, as mentioned in the previous lecture, don't agree to give for free this data because obviously it will give competitive advantage to others in the market. And in my opinion, you should focus on implementing standards, as it is actually the topic of the current session. And this way we can avoid depending on the free will of this or the other hospital or health information system for providing data. Rather, it will be legislation that makes providing data obligatory according to standards, as we have heard here, the implementation of the ICD terminology, SNOMED, and other standards that make data specific to health, and it is rather different from data in other sectors. This is obvious. And as mentioned by Mrs. Chronaki, the IPS standard is subject to implementation not only by FHIR, but for instance in OpenEHR or in the ISO 13606 standard, and it makes creates an issue that all these implementation, physical implementation of the IPS standards should be compatible with each other, and this is another issue that we have to focus on. Yeah. Therefore, I think we have to focus our attention and the people that have really the power to implement terminologies and standards national-wide in the European Union. And it is a really cost process that takes a lot of effort and costs. For instance, in Bulgaria, it is difficult to translate SNOMED or ICD, the terminology. It should be a matter of legislation, and the people responsible in the government for implementing these standards should be involved in this subject. Therefore, my question is, what are the efforts of, for instance, of the World Health Organization for, or also, for instance, Mrs. Chronaki perhaps will take attention for implementing these terminologies and standards nationwide in the European Union. It would help to, for instance, implement cross-border exchange of e-prescriptions, the IPS, Otherwise, this will be a great obstacle for implementing this trans-border exchange of IPS and e-prescriptions.
Yeah.
Thank you.
Maybe.
I'm just going to ask for us to be short now.
Yeah, I can
because
be quite short on my side. In different initiatives in Europe, terminologies are taken seriously. HR7 affiliates in national governments are implementing terminology infrastructures to make this happen. On the part of collaboration and indirectly also answering to Dr. Jakob's comment earlier, there is a big effort in the Joint Initiative Council to include also WHO as an observer. This is a forum where HR7, IHE, SNOMED, LOINC are participating. So recently there is a move to change the bylaws so that we include observers, and WHO is the reason that this is happening. So I do hope that the future discussion on the IPS will include all these entities so that we can actually make things happen irrespective of the actual flavor that one chooses to implement things. Thank you.
Just to complement, if you allow me, I remember working on the APS standard because I'm part of a team that implemented the APS standards in OpenEHR and 13606. We had a big problem, by the way, with the with the drugs, the IDMP standards. They have been implemented for years, and up to my knowledge, they are still not in Bulgaria, for instance, they still are not implemented. The Bulgarian Institute of Standards has not made the necessary steps to implement it countrywide. I expect it to be so in other European countries. So this is a big issue also because you cannot create the IPS, as you mentioned, the record without having the terminologies. The IDMP are critically important for this standard.
Thank you. I think Jakob also wanted to make a comment, right?
So regarding the implementation, we are supporting countries that request this from us. In the implementation, we are not funding the implementation, but we're giving technical instructions, training materials, and other elements so that implementation can happen. And we don't have yet a Bulgarian translation, but I see there Slovak, Slovene, and some other languages. So I trust we'll find also method, and Hungarian. So I'll trust we find a method also to have Bulgarian included in the translation effort, that you can use the ICD and its companion classifications. For the international patient summary, yeah, it's unfortunate that this design has been made without WHO. It's good that WHO is there. It should be there as a partner, as it's a standards organization and not just as an observer. So, and that what was said I think 2 years ago when the conversation started, that we are a standards organization, so we should be there as a partner. That's a separate discussion, but that we also can make sure that in the specifications of the group, the relevant standards that are established are taken into account, and also the parameters that are necessary to provide then useful information, as Steve was saying, are complete. Otherwise, you will collecting something. But of course, all of this does not solve the issue that we had, for example, with the COVID pandemic, where there were incomplete coverage of diagnostic, different ways of approaching this, different definitions despite WHO definition, and government regulations interfering with this, where we just say that it's nice that we have an electronic system that can convey the information, but as Steve was saying earlier, we don't, in some instances, have to have difficulties in then interpreting the information in the correct way so that meaningful information can be extracted from this. Back to you. Thank you.
Thank you, Jakob. And I think, sorry, Paulo, we're going to extend a little bit more because it's not that often that we have these people and 100 people, half of them here, the other half online. So let's take advantage of that.
Yeah, thank you.
Hello, my name is Cristóbal Bernardo, and I work as a project manager in Vaya Software, an SME IT company from Spain. We are participating in the EDEN project. And I have also another question out of this data quality. we had the opportunity to work in a European project with state-of-the-art technologies, cell sequencing technologies particularly. And these technologies generate a vast amount of data. And the researchers need the raw data to perform the analysis, the pipelines, and also the machine learning algorithms. And my question is, what is your opinion about the use of cloud technologies in the healthcare systems? Because I think that these technologies are, they have advantages in terms of clinical trials, in terms of CAR-T technologies. And I think that thousands and thousands and thousands of terabytes could be a complex problem in the future for data quality and all these things. And perhaps the cloud technologies could be a solution, but I don't know the opinion of the healthcare leaders in this regard. Thank you.
Well, I can just tell something on top of that. It's a dangerous question because cloud technologies can mean so many things. I'm not really sure if we can answer as a whole. But I imagine that at least there is the legal part, then there's the infrastructure part, and the capability of processing data. So, well, I invited the people here maybe to address one of these if they feel. I don't know if Carlos, Jakob, or
our book today is about interoperability standards, not about cloud. But in any case, I think the cloud has a brilliant future, but the cloud can be very complex in the concept of how can use, for example, healthcare providers, big healthcare providers like Andalucian Health Service, can develop his roadmap about storage data in the context of cloud, but can combine different level of cloud and different privacy and limitation to the access. Also, part of data on premise and part in some cloud. It's not the answer is not yes or not. I think in the future we will use cloud, of course, but in all time we will need to improve the security measures, but not only for cloud, also for all kind of systems to storage and handling data.
Thank you, Carlos. Jakob?
Yeah, so while cloud depends exactly what kind of cloud, what do you do in the cloud? And so, for example, our coding engine and infrastructure runs on the cloud. On the other hand, because some countries or some places have concern about data safety, confidentiality, and other things, we of course have an offline package that then can be run on local computers, local servers, so there shall be no concern. And in this, the other side, one can say the cloud for data storage. Well, we have a tool that can check the quality of your national statistics. But for example, this is deliberately designed in a way that it does not automatically store the information. It still runs on the cloud, and it clearly displays that we don't save anything from that. But still, there is an offline version to solve the concerns. And I think the most important point is that Steve made earlier, that people need to be convinced that their data is handled in a confidential way with good governance. And that's then not a question of the cloud, but of the governance of the data there. Over to you.
Yeah, may I add also the efforts of the European Open Science Cloud, which is something that in my capacity as EFMI past president, thanks to the effort of Carlos Parra, our treasurer, has been associated with the European Federation of Medical Informatics. So this is a European effort to coordinate and govern the research data on the cloud. And I think this is an instance of this fundamental shift that we have towards more data governance.
Thank you. I think we can close now. Well, first of all, I had a lot of questions here for you, so it won't be today. But just two or three last comments. I think that one thing that we are actually trying to move forward without saying wide open is that we are aiming for somehow a common language, which is something very hard in this area. And I think at one moment we will need to talk about education, because if one way to tackle with part of this is try to teach the health professionals in particular, and actually all of us as citizens, on this common language. So this is something that I think we should also start to discuss about. Another thing is that I think there is a really big difference between data collected automatically and data collected by humans. Some of the issues regarding data quality are typically addressed to humans, to data collected by humans, where actually you need to interpret the data, and others that's collected by machines. It's a little bit easier, I think, or at least the data quality issues are different. And so I think that we should start to understand that two different data sources also need different ways to address this. And as far as I know, the data collected by machines is growing much faster than the other one collected by humans. So we also need to look at this. And finally, and this is more for the people concerned with databases and more of the informatics part, we really need, in my opinion, to move to get new ideas on how to store data on a very low level. It's, at least for me, it's very strange while we still have to transform everything into floats, integers, strings, and dates and booleans, which is in the end, everything seems to, we need to transform everything into this. And most of the people that I see working in IT, in health, these are, when you talk about data types, these are the things that come to their heads. And these are, I would say, too basic. They are too basic stuff. We need more complex things. Some of these standards have already started working on, they have different types of data types, more complex and more appropriate to health, but they are not taught. Most of the people that work with these things, they don't speak this level. They still speak booleans and integers and floats, which is very basic stuff at least I'm concerned. So again, thank you very much for being present until almost 1. And we are 100 people, both online and here. So thank you very much. Back to you, Paul.
Thank you so much. Maybe we can close now the live stream session. Thank you so much, Zoom participants. Thank you so much for so many people watching us live online. This was really a very interesting parallel session, attracting lots of interest. Be advised that the lunch is going to be served in the U restaurant for the participants with badges. Please take your badges to the lunch restaurant. In the reception here of the upstairs, they can provide you directions where it is the U restaurant. We have to be back in 45 minutes, I'm afraid. So even less or a quick lunch, and then come back as the session starts in 45 minutes. Thank you so much. Goodbye for now.